Vishal, once again, revolutionary change in obesity treatment. Let's see what he has to say. Things from the STEP trials.
So, revolutionary changes in obesity treatment, transformative weight loss from the STEP trials. No disclosures, the agenda, which discusses the following. Okay, so the drama is over. Now, I'm opening up a completely new facet to the use of GLP agonists in people with cancer. I'm going to try to highlight the association of diabetes with cancer, the association of weight with cancer, and where does this all fit? So before we start, I want a show of hands. How many would use GLP agonists or the GLP-1 agonists during or after cancer therapy? Raise of hands. Okay. So only for obesity is Dr. Chandra. Dr. Vaishali says she will use it during and after. Is that despite the fact that the cancer specialist will tell you, oh, my patient's not eaten, the nutrition is low, and if she loses weight, I'm going to be confused as to whether my treatments are working or not. That's their traditional fear, right? And that they need to come out of that. As I said, I'm going to take you through a little journey. I want you to quickly answer this question, give you some options. So, a known diabetic with cancer, the HbA1c is 7.5. Which combination of diabetic lowering therapies would you use? Would you use metformin along with basal bolus insulin therapy? Metformin with, so first option, how many would raise the hands? And you can keep raising your hands for multiple options, I'm okay. So somebody with cancer, I'm not mentioning the cancer, somebody who's got an A1C above 7.5. Why do you really want to bring the A1C down below 7? That's the first question you want to ask. So Dr. Mashru is making an association of diabetes and cancer, which we will highlight. My question is, do you think that an A1C of 7.5 will compromise her immunity? Do you think it will add to the risk of stroke, heart failure, ischemic heart disease death? Do you think it would do all this? Do you think an elevated inflammatory screen would contribute to death? And this is how I want you to start thinking. The question is whether you're doing it during chemotherapy or after chemotherapy. That is a choice, but I'm opening up a new door to your thought process. Metformin, gliptin, SGLT2, pioglitazone. So if you notice what's unique to all this, it covers different aspects of the pathophysiology, and they are all anti-hyperglycemic. So there's no question of a low blood sugar attack, which is a very potent risk in somebody on cancer treatments because of the nausea, the vomiting, the GI discomfort, etc., etc. How many for the second option? We have one. Use of semaglutide in any dose that provides organ protection without the risk of muscle loss, along with anti-hyperglycemic OHAs. How many for the third option? So we have a few more. Vaishali, you're raising your hand for everything. Tirzepatide or semaglutide, with the focus being weight loss to improve cancer-related outcomes, to improve mortality and morbidity. So we have Dr. Naveen Chandra who says he'd do that. And the fifth is none of the above. So all of you are none of the above, I'm assuming, because nobody raised your hands for any of the options. Okay, fine. So I would go with option 4, as Dr. Naveen Chandra would. Dr. Sethi, which option would you use? Okay, excellent question. Excellent question. Excellent. So I haven't highlighted the stage of cancer. I haven't highlighted the degree of cachexia. I have not highlighted the patient's quality of life. I would do an SF36 and find out where they are at that point of time before you choose any option. Now it would be just HbA1c control to improve inflammatory outcomes and infection outcomes is what I would think of at this stage without that information. Okay, a little about the distribution of the receptors, and I want you to keep this in mind. So look at first let's start with the blood, the immune system. So the lymphoid system, the lungs, the pancreas, the brain, the GI tract, the most important, the liver. So the GIP receptors concentrate much more on the liver compared to the GLP. As Dr. Sethi highlighted, the role of compartmentation of the energy by GIP, because they are prevalent in the fat cells, predominantly in the subcutaneous fat cells. Rutatrutide, the rutatrutide add-on organs would be the heart, would be the skeletal muscle over and above GLP. Now I want you to pay attention to these organs. So we have the brain, we have the lung, we have the kidney, we have the GI tract. I want you to also think about the fat cells, hormone production, aromatase, and the creation of female and male hormone that accentuates with the fat cell, and therefore by reducing the fat cell, what benefits you might achieve when it comes down to the overall progression of any mitotic lesion that they may have, right? Go to the insulin receptor, type 1, type 2. We have A and B. We have predominantly metabolic and mitogenic pathways. The IRS, metabolic. We have the MAP kinase, the mitogenic. Greater the insulin resistance, greater the insulin resistance, greater is the production of IGF-2. You're talking about peripheral conversion of enzymes, and therefore their effects on the fat cell. Now this is a little paper I want you to absorb this. The difference between, so this was a lovely study that took Europeans, that took the Asians, Indians particularly, both had a baseline BMI of 22 kilograms per meter square. They fed them for 4 to 6 weeks. They made them gain an average of about 4.5 kilos. What they found was at baseline, the fat cell was 18% more in diameter, 78% more in volume. The percentage of fat cells were 3 times greater in the large lymphocytes, and the small lymphocytes had 2%, had twofold lesser volume. So which meant that at the start, when they compared their muscle to fat ratio, the Indian had much more fat, less muscle. They had a triglyceride response 50% more than the white at baseline. They had an insulin response 60% greater at baseline, saying they were more resistant. But when they did the Matsuda insulin sensitivity index, they matched both the Asian and the European, telling you that they were compensatory mechanisms or they didn't do the right sensitivity index. When they made them put on weight, to the tune of about 4.5 kilos, what did they find? They found that the European gained 4-fold larger muscle mass compared to the South Asian. They found that the insulin sensitivity worsened 5-fold in an Asian compared to a European. And they found that the postprandial insulin secretion was 4-fold higher. What does that tell you? That tells you that the average Asian is genetically predisposed to retaining fat and losing more muscle in response to weight gain. So there's something different about our makeup compared to the white. Now I want you to take this association with cancer. So I'm going to divide this into severity of glucose, metabolic parameters, the relationship between BMI and cancer. We've highlighted that BMI is not the best weight parameter. So I'll show you the waist circumference relationship to cancer, and we'll go stepwise. Now, I thought I'll just bring up this very old association, which is now called stage 3C cancer as the pancreatic, as a structural pathology associated cancer. And when to suspect this? New onset cancer, that's in somebody above 60 years of age. Somebody who has unprovoked weight loss of more than 5% in 6 months. Somebody whose glycemic control rapidly changes where the OHAs fail and they require insulin therapy. Somebody who's got symptoms, obstructive jaundice, symptoms from what is perceived to be related to the pancreatic structure, and raising levels of CA 19.9. You know, a lot of your patients who come to you, they're serially doing health checks, and those health checks include the cancer markers. So, what is the cancer story? So, more than 5,600 diagnoses of cancer per day, more than 600,000 deaths of cancer per year. 1 in 5 is going to get cancer through their lifetime. Taking the percent, so I now I'm intentionally made it scary compared to what Kanisha told you about 20% versus 1 in 5. The data is 1 in 3 cancers in a woman above 55 years of age when you take uterine, ovary, and breast put together. So, what is common to these cancers? Risk factors were obesity and diabetes. What is common to people with what is the common risk factors to both? Age, smoking, sedentariness. See the data on sedentariness. People who do less than 3.5 mets per day. So if you have 1 hour of sedentariness a day for more than 1 year, that can accumulate 1.1% fat in the liver. Now, one addition to this is blood pressure for renal cancer. So when they looked at the SEMA data and the GLP data for cancer risk reduction, there was one cancer that they found an increased signal for, that was the kidney cancer or renal cancer. When they looked further into the data, they found that the people smoked, they were diabetic, and these were the people who did not lose weight on the GLP, GIP analogs. So these were the people who did not respond to the agonist weight losing therapy. I want you to keep this in mind. BMI has been shown to increase the risk of cancer twofold compared to a diabetic. When I gave my first talk, I told you view a diabetic as obese because somebody is driving the pathophysiology, whether you can see it or not. So think about the visceral obesity and now try to correlate the visceral obesity with this talk. Now this is a little data I thought I'll highlight because I want you to focus on 4 things. Stroke death reduction, their inflammatory CRP response, heart failure death reduction, and improvement in the metabolic parameters. Why this is important is when somebody undergoes cancer therapy, whether it's chemotherapy, anthracyclines, checkpoint inhibitors, TKI inhibitors, whatever they are undergoing, the HER2 agonist therapies or HER2 antagonist therapies, these are all cardiotoxic. Radiation, cardiotoxic. Cancer itself is cardiotoxic from multiple mechanisms. I will show you the strongest association of cardiac mortality post-cancer occurs in the first 6 months to a year. Radiation takes that risks on a continuum basis for 3 decades. And the single largest factor that controls mortality is the NT-proBNP. We know GLPs, particularly semaglutide, has shown to increase atrial contraction by 22%. We know heart failure death comes down right from the FLOW and the SELECT trials as early as the 18th day, with an escalation of protection on the 30th day, 60th day and 90th day going up to 34 and 40%. CRP comes down by 43% with the 1 milligram, going up to 63% with the 7.2 milligrams. The same is seen with tirzepatide in the 15 milligram dose. We've got, this is the only, so if you go by stroke, it was the initial pioglitazone study in people who were pre-diabetic that showed stroke death reduction. Amongst the SGLT2s, if you remember, EMPA had an increased signal with a hazard ratio of 1.24. It wasn't statistically significant. The only drug that showed significance was canagliflozin. And canagliflozin showed a 49% death reduction for stroke in people whose EGFR was less than 60. Telling you the more the drug, and we know the more difficult the patient with kidney outcomes, the better the benefits that were seen. This is the first time you've seen that there's stroke death reduction, and why this is important is because 1 to 2% of cancer-related deaths are going to be stroke deaths. 30% deaths within 1 to 5 years are going to be cardiovascular deaths. People under 35 diagnosed with cancer are going to have cardiovascular deaths, 30%, and 76% of these deaths are ischemic heart disease related. So what do I want to prevent? I want to prevent the inflammatory response. Why? Because when they looked at the BNP, CRP and the highly sensitive troponin INT, they found that CRP correlated with the BNP directly for cardiovascular mortality. Now, I'm interested in this group of drugs with the CRP, with heart failure because of the BNP. I am interested in the SOUL data and the myocardial infarction data. I am interested in MACE reduction, 3, 4 and 5 point reduction. And I'm interested in ventricular arrhythmia reduction. As you know, when they compared it with albiglutide, there was a 57% reduction in arrhythmias. These are the predominant causes of death in people diagnosed with cancer in a World Heart cohort, irrespective of cancer. When they start their treatment between 1 and 6 months, 6 months to a year, and for every 1 gray of radiation received, death increases by 7.4% in an incremental factor over 3 decades. Now I'll ask you the question again. Would you want to consider GLP analogs? How many people would raise their hands here? Still nobody? Okay, so we have only Vaishali. She works with me. She's paid. So she doesn't count. Okay, let's move forwards. I'm going to show you data that you all don't know or not aware of or may not be. The step up 7.2 data of semaglutide. I've already told you on the weight loss. I've already showed you in my last talk 11.7 centimeters over 2.4. I've showed you intra-muscle 10%, total fat loss 24%. Twofold greater people achieved weight loss of 20% and more. 1.5 times for 25% and more. And the GI side effects, the question you all would all have, what happened in the trial with the GI side effects and how many fell out? Actually, the GI side effects were slightly lower in those on 7.2 compared to the 2.4 dose. I wouldn't put it out that way. I would just say it doesn't increase. That's how I would say it. So my outline, which I've already told you, relationship of various adiposity markers with cancer, the mechanisms, the relationship or association of cancer with cardiac mortality, and the role of GLPs in this situation. I'm taking you away from a traditional thought process that we've been doing for the last 100 years, guided more out of fear of the unknown. So what did the risk factor and the life expectancy project tell us? More the metabolic markers, greater was the mortality as much as 3-fold. What did a study on over 200 patients with diabetic tell us? That if the HbA1c was more than 8.5, there was nearly a 20% increased death rate in breast cancer and colorectal cancer. I'm going to go to the parameters. Now, these were breast cancer patients who were ER positive, PR negative, HER2 negative. This was from the Women's Health Study. what they found was there was a 44% increased risk of breast cancer related mortality in these people, directly related to the number of components of metabolic syndrome. So if they had 3 or more components, the death rate kept escalating as per the number of components. This was another study that included 33,000 people followed for 14 years, that showed that the mortality was twice seen in the WHI study of as much as 83% for those people with 3 or more components versus people who did not have any component. Now, with regards to the BMI, now for every 5 kilogram increase in BMI, go back to the distribution of cancers based on the receptors. Lymphoid system, so multiple myeloma, lymphomas, go by renal carcinoma, lung carcinoma, meningiomas, pancreatic carcinoma, and all the hormone sensitive tumors, postmenopausal breast, uterine, and prostate. What is marked in red is common to males and females, and you see there is an 85 to 90% association with the distribution based on the receptors. I told you that the BMI contributes to twofold greater mortality, and we know that for every 4.6 increase in 4.6 kilogram per meter square of BMI, pancreatic cancer increases by 34%. Vishali is trying to tell me something, I don't know what. Either shut up or move on. 1.1 to 1.13% increased risk of cancer for every kilogram increase in weight. And these cancers are strongest for endometrial liver, kidney, and pancreas. Now you see colorectal cancer, there is an intermediate association. And the reason is, it is more associated with the waist circumference more than anything else. So, for every 2 centimeter increase in waist circumference, colorectal cancer increases by 4%. So what are the mechanisms? A very fancy story, but in a sense, your inflammatory cytokines, your adipokines, stimulation of receptors, your aromatase, increasing female hormones relative to the male hormones for a woman, and their associations with the receptors stimulating the mitogenic pathways and not the metabolic pathways. So this was the association of mortality in all cancers, and I want to bring down the NT-proBNP's relationship with cancer, which I told you. So there was an 8-fold increase in the BNP in as much as 3 months of chemotherapy from the start to 3 months later. This data was on anthracyclines. So the doxorubicins, which are a very important component of most cancers that we treat, or what I've just mentioned, including breast cancers, who have got even stage 1 cancer, but if their lesion is, even if it's in situ, and the lesion is above 4 to 5 millimeters, chemotherapy is suggested to reduce overall mortality. People with pre-existing heart conditions had a greater mortality. The radiotherapy association that I told you, 1 Curie Gray, 7.4% increase in the risk of death, and this continues over 3 decades of life. BNP is an independent marker of ventricular arrhythmias and sudden death in these people, most commonly seen, as I told you, in the first 6 months to years of therapy, going up to 5 years. Now the question, can GLP reduce the risk of cancer? So this was a large UK-based study. What they suggested, that if the whole United Kingdom took the GLPs in people classified as obese, and you brought them just by one category down, you would save over 22,000 cancer deaths per year. And imagine we are not talking about one category. When we talk about GLPs, you're talking about, as Dr. Sethi showed us, 80% of people achieving more than 15% of their body weight. You brought them down by minimum two, if not more than 2.5 categories of BMI. So, is this something that you would do? Yes. And what were the cancers that benefited? Liver. We know association of NASH and liver. Kidney, I told you a little earlier. Colon and uterine. I told you colon with waist circumference, and the others were related to the BMI, if you remember from the data I told you. Question is, does semaglutide have an edge? So when they looked at, I looked at a lot of data sets. I want to address two particular things. A patient, they routinely, when they come to you, thyroid cancer and GLPs, they come in every discussion. This was one set that showed you that thyroid cancer reduced 29%. It didn't increase, it reduced. The other cancers are in keeping with the distribution of the receptors for GLP and GIP. This was another study that suggested the same thing. Now, this was a study that compared all the GLP agonists till today. And what they found was semaglutide had an edge, particularly in gastrointestinal cancers, to the tune of 55%. That means a 1.5-fold reduction in the risk of gastrointestinal cancers over the other GLP agonists. I'll come back to my question, and I hope I've changed people's minds. 7.5 A1C, now I'll categorize the patient. The patient has no distant metastasis. Patient is in stage 1 or 2 cancer. Patient is afraid to die. She's afraid of dying from cancer-related death. Her quality of life, would you want to change the outcome? You know data on global left ventricular strain and the GLP analogs. So it starts saving the patient from day 1 that you use it. You start seeing the effects as early as 18th day. I've showed you the NT-proBNP is the strongest marker of death. Now on that, would anybody use option 4 except Naveen Chandra and Dr. Teli? They were the only 2 people. I've got Dr. Sethi. Again, I'm talking about NT-proBNP. And I will come in my third talk where I will tell you that semaglutide's effects are weight independent. When I say weight independent, I'm saying up to 90% for reduction in EGFR, renal death, 3-point MACE, 4-point MACE, 5-point MACE, individual heart failure death. The only 2 places where it scored 70% was new onset albuminuria and all-cause mortality. Now again, after answering this question, would anybody use low-dose semaglutide, even 0.5 milligrams? Not 2.5, not 7.2, but 5 milligrams or even 0.25 milligrams. Understand, if a patient, I always teach Dr. Vaishali, if a patient can't tolerate even 1 milligram, 0.1 milligram, it is working for them. It means that is equivalent to the 1 milligram who tolerate it easily. So if I tolerated 7.2 easily, my dose is equivalent to the 0.25 who can't tolerate 0.5. So don't forget that. Right? Now, I'm desperately trying people to raise their hands. Oh God, come on. Okay, I won over Dr. Mashru. Okay, good, I won. Okay, on that note, I conclude saying I would use it. I use it. And I have my to-go person too is always Dr. Bowman Dawar. And I always get to one thing with Bowman. Vishal, your patients, I don't have to worry about heart, kidney at all because you take care of all the shit. I don't have to refer the patient anywhere. I can send them back to you and I know you will sort that shit out. So on that note, I hope I've opened up a new dimension to the use of a GLP in people. You don't even have to do it during chemotherapy. You can do it after. I said the death is 6 months and 1 year. You can let the chemo get over and then you can start escalating.
Thank you, Vishal. Very illuminating talk. So we have to understand the take-home message is that the molecule has merit of its own in preventing cancer besides weight loss.
I'll show how it's weight independent.
And is it contraindicated in kidney failure? Semaglutide?
So the only data we have is from the ADA from 5 years back, when in stage 5 kidney disease, the use of liraglutide was used and it reduced death. It presented as a poster. So
Okay.
I use it in
Okay.
a dose of 0.5 milligrams, not more, because I don't want nausea and vomiting and diarrhea, and I don't want it to get worse. I don't use it in more than 0.2 or 0.5, and I wait for up to 6 months before I escalate.
Okay, thank you. Any comments? Yeah, come on, Naveen. One quick comment.
What is the role of metformin now that it has been increasingly used in cancer?
So, see, is there any data? Answer is no. I only know that the Nobel Prize for metformin was given on the theory of weight loss, where they used 3,000 milligrams of metformin. Again, to get that, would you use it? I had 2 patients where I looked at the pharmacogenomes of the use of conventional drugs. And the only thing in those studies was vitamin C and metformin that was cancer protective by 28 and 42%. But this is something I've seen from the American reports, not something locally. So, yes,
Second thing is, would you want to do anti-BNP in all the patients of cancer?
I do it universally for every single person in our clinic.
So should it be more usable or should it be done more
So-
often
so
than
for me it's
because
easy.
We don't do it.
For me, it's easy because I've brought the rate down from 3,000 to 1,500 in my practice. So, for that, it becomes easy for me to do it for all my patients.
See, what we do is we do it very rarely.
Yes.
Unless and until it's proven heart failure.
Yes.
So that's the trouble, you know. So
Yes.
we are missing a lot of.
Yes. Agreed. Agreed. Yes.
Okay. Thank you.